Hello again, everybody. Today we will continue the talk on acute coronary syndrome that included unstable angina and myocardial infarction. Just to remind you, the coronary arteries are mainly the left coronary artery that divides into left anterior descending and the circumflex, and the right coronary artery. These are the main three coronary arteries, and we have secondary branches like obtuse, marginal, septal, diagonal, posterior, descending. In the previous lecture I talked about definition, pathogenesis, clinical features and risk stratification and complications. Today I will talk about investigations and management of acute coronary syndrome. The investigations are mainly ECG and cardiac markers, then echocardiography, sometimes coronary angio and chest x-ray. Just to remind you again, when we said acute coronary syndrome is divided into unstable angina and myocardial infarction, and myocardial infarction was divided into two types, transmural infarct and subendocardial infarct. This was an ECG classification. By ECG, when a patient comes to you with chest pain, ischemic chest pain, severe, prolonged, central, then he is an acute coronary syndrome. The ECG is either of the two possibilities. Either there will be ST elevation, which we call it ST elevation MI, or there will be no ST elevation, non-ST elevation MI. The ST elevation means there is occlusion of the coronary artery, of a major coronary artery. There will be a transmural infarct and Q wave. Here there will be release of intracellular enzymes and markers. In non-ST elevation MI, it's either subendocardial infarction or unstable angina. In subendocardial infarction, again there is infarction, but it's partial thickness. Again there will be release of cardiac markers, but not to the extent of transmural. In unstable angina, there is critical narrowing of the artery, but there is no necrosis of the myocardium, so there is no rise in cardiac biomarkers. Now I will talk a bit in detail about the ECG. The standard 12-lead ECG is almost always diagnostic of acute myocardial infarction, except when you have left bundle branch block or previous MI. But remember one important thing. The initial ECG might be normal in 1/3 of the patient. So when a patient comes to you with typical chest pain and the ECG is normal, don't discharge him or don't tell him that everything is okay. Especially when the pain is typical and he has a risk factor. Even he has epigastric pain and diabetic, or central chest pain and smoker, etc. Then you should repeat when the diagnosis is uncertain, or if the patient has recurrent symptom or persistent symptom, always repeat the ECG. The initial ECG might be normal. The ECG then will show, as I told you, either of the two possibilities, ST elevation, which indicates occlusion of a major coronary artery, say the right coronary, left main stem, left anterior descending, circumflex, where you have ST elevation and transmural infarct. Sometimes you will have no ST elevation, and let's say ST depression or T inversion. This is partial occlusion of a major, or complete occlusion of a minor vessel, say diagonals, obtuse, marginal, etc. But again, it is not only ST elevation. When you have only ST elevation, this is probable infarct. There is a sequential change or evolutionary change. The first thing, you have ST elevation that indicates a current of injury within minutes. This is the normal ECG, and this is the ST segment, and this is the ST. This is the earliest change. Actually, there is another change before that called hyperacute T. This is the current of injury. Then this R wave will diminish in size, diminution of the R wave in a matter of hours. Then when you have a transmural infarct, you will have a Q wave. and then the T inversion will start in a matter of days and even become smaller, but the Q wave will remain permanent. These are the evolutionary changes in matter of minutes to hours to days in acute transmural myocardial infarction. But in non-ST segment acute coronary syndrome, that's say unstable angina or partial thickness, then you have ST segment depression and T inversion. This is the T inversion. To differentiate these two, partial thickness infarction and unstable angina, sometimes we have loss of the R wave in the subendocardial infarct. Now, by now we diagnosed myocardial infarction from symptom and ECG. The next step is to know which wall is involved to assess the extent of infarction. For example, this is the heart. The left ventricle has three walls: anterior, inferior, and posterior. According to the artery, this right coronary artery supplies this area. The left anterior descending supplies this area. The circumflex supplies the posterior and another part. So when you have infarct, the ECG changes the wall, reflects the wall that's affected. In anteroseptal infarct, the changes are seen in V1 to V4. Anterior is divided into strict anterior, anteroseptal, and anterolateral. Anteroseptal V1 to V4, anterolateral V4 to V6, and lead 1 and AVL also. Inferior wall, this will be seen in lead 2, 3, and AVF. Posterior wall is not seen because we don't have ECG in the posterior wall, although occasionally we can do that. Actually, there will be a mirror image or reflection of the changes in V1. So the V1 sometimes, instead of the reflection of ST elevation, will be ST depression, and the reflection of Q wave will be R. So you have tall R in V1, sometimes V2 or V3, and ST depression. The last thing, the right ventricular infarction, this is usually an extension of inferior. Whenever you have inferior infarct, always do right-sided ECG, especially V4. When you might see right side V4 ST elevation, this indicates that there is extension of the inferior infarct to the right ventricle. And as you remember, these patients might have hypotension where the treatment is IV fluid. This is all about ECG, and these are examples. This is a patient with recent chest pain, acute chest pain. Here you see this is lead 1, lead 2, lead 3, AVR, AVL, and AVF. The V1, V2, obviously, sorry, you can see very clearly, sorry, very clearly T inversion in lead 2, 3, 4. This is subendocardial myocardial infarction or possibly unstable angina, depending on the enzyme. Here you have another patient with chest pain within 4 hours. This is, by the way, from your textbook. Severe chest pain, and this is lead 1, 2, 3, AVR, AVL, AVF. Here you see clearly ST elevation in lead 2, lead 3, and AVF, and even some reciprocal changes in V2. This is inferior wall myocardial infarction. Another patient, 6 hours chest pain. You will see this is 1, 2, 3, AVR, AVL, AVF, V1, V2, V3 till V6. You will see here clearly ST elevation in V2, V3, V4, V5 with 1 and AVL. This is anterolateral myocardial infarction. So by ECG we can diagnose the myocardial infarction, and then we can tell which wall is involved. This is all about the ECG. Now, the second important investigation is the so-called plasma cardiac markers, or enzymes and proteins. Whenever you have infarct in the wall of the ventricle, you know the muscle is composed of myofibrils, etc. The contents are released to the circulation in a sequential manner. But these are not released, by the way, in unstable angina, but in myocardial infarction you have a rise in these enzymes and proteins. What are these enzymes? The first is creatinine phosphokinase, and it has many types. The M band, M form, is the cardiospecific, and you have cardiac specific proteins called troponin T and I. These are released to the circulation after myocardial infarction. Level of these or detection of these indicate that there is myocardial necrosis. Sorry. Now, the first enzyme to start, the first one we talk about is creatinine phosphokinase. This is the creatinine phosphokinase. It has, by the way, two curves. Actually, the first curve is sudden rise of creatinine phosphokinase after reperfusion. Anyway, it will start to rise within 4 to 6 hours, peaks in 12 hours, and falls to normal within 48 to 72 hours. The next enzyme or protein is the troponin. This is the most sensitive one. Cardiac troponin T and I starts to rise in 3 to 6 hours, peak in 36 hours, and remain elevated for 2 weeks. By the way, there are other markers, but they are not specific. For example, you have AST, aspartate transaminase, and lactic dehydrogenase, LDH. These are released from myocardial cell, but they are not specific because they are released from RBC and liver. These are the two most important investigations. Now, you might do a full blood count for leukocytosis. The ESR and C-reactive protein will be elevated. Lipid measurement is important within 24 hours because there will be transient fall in cholesterol in the first 6 months. Chest X-ray radiograph for pulmonary edema. Echocardiography for assessing ventricular function and complications like cardiac failure, etc. And you might ask about coronary angio. This actually for postgraduate or for 6-year students who are listening to this video. Coronary angiography is done in moderate to high risk patients when they have a risk of further event. Who are these patients? Who are those who are not settled on medical therapy, those with extensive ECG changes, sorry, those with elevated plasma proteins, apparently I am having now coronavirus, and those with severe pre-existing stable angina. Now the next topic will be, this was all about investigation. The next topic will be on management of acute coronary syndrome. Now, management of acute coronary syndrome. The management is actually of two parts. Management of acute event, that is immediate in hospital management, usually within 12 hours, and long-term management when you discharge the patient. Obviously, whenever you see a patient with chest pain, typical, etc., the normal situation is to admit the patient right away in a coronary care unit because there is risk of death and possibility of recurrence of ischemia. You should tell the patient that medical treatment will or might decrease complication up to 40% because some patients are not convinced why to be admitted in hospital. You should tell them that there is a risk of death and recurrence of ischemia can be decreased up to 60%. And then you assess the patient by GRACE score, whether he is a high risk or low risk. If he's a high risk, then you need an early intervention. If no risk, when there is no complication or no angiography is not needed, then you can mobilize him even after second day and discharge home after 3 days. Now, what are the points in the management of acute coronary syndrome? I am mentioning these, but they are not given for all patients. Some must be given for all, the others are individualized. It's not a matter of enumeration. All patients should be given analgesia. Reperfusion therapy is considered when you have ST elevation myocardial infarction, not in ST depression. Antithrombotic therapy, this includes antiplatelet drugs and anticoagulant. Be careful of this terminology. Antiplatelet and anticoagulant are thrombolytic, while in reperfusion therapy are antithrombotic. In reperfusion therapy we have PCI and thrombolytic. Thrombolytic is to dissolve the thrombus or fibrin. Antithrombotic prevent. Anti-anginal therapy, this is not a routine for all patients. Certain patients need these drugs. Renin-angiotensin blockade is in certain patients, most of them. Mineralocorticoid receptor in some of them. Lipid-lowering in all of them. Smoking cessation in all. Diet and exercise in all, and rehabilitation. Now let us start. This is a diagram from your textbook. It's a bit difficult, but look carefully at the picture later on. Immediate, when you have a patient suspected of acute ischemic event, do an ECG and troponin, and immediately you admit the patient to the CCU and you give him oxygen. Put the patient under monitor because he might run an arrhythmia. Put an IV line. This is a routine work for every patient. Immediately admit, put under monitor, give him oxygen, and have an IV line. Least he might develop shock and you don't find any vein. Then immediate to antiplatelet. I will give detail of these. Metoprolol in some of the patients you must give, and then see whether the patient is having ST elevation or not. If ST elevation, this is a difficult diagram, then you do either PCI or thrombolytic. If ST depression, low molecular weight heparin, remember this, with other treatment, again assess. If high risk, again consider angio. If low risk, then medical treatment. In summary, immediate initial management, oxygen, IV line, monitoring, beta blockers, dual antiplatelet, etc. ST elevation, reperfusion. ST depression, low molecular weight heparin with other treatment. Reassess the ST depression. If high risk, angio, low risk, medical treatment. Actually this graph again is for 6-year student if they are listening to this. Now what about analgesia? This must be given for every patient. It will relieve distress. It will lower adrenergic drive and reduce vascular resistance, blood pressure, infarct size, and even susceptibility to ventricular arrhythmias. The analgesic should be narcotic one. Opiate intravenously. You have the morphine and diamorphine, and you should know the dosage. With this, you must give an antiemetic because it will cause central vomiting. Then repeat small aliquotis until the patient is comfortable. Analgesia for all patients. Next, you decide about reperfusion therapy. I'm talking about a bit detail of this. It's not necessary for all 4-year students. Reperfusion therapy is either primary percutaneous intervention or thrombolytic therapy. Of course, this again, for those who are interested, especially 6-year, are asking about this. PCI, primary percutaneous intervention, is indicated when you have ST elevation or you new bundle branch block. It has no benefit in patients with non-ST elevation MI because you don't have an occlusive thrombus. Timing within first 12 hours, better within 1.5 hours. Benefit, it will preserve left ventricular function, reduction in progression to heart failure, halves the rate of recurrent MI, and even improve mortality and remain for that and decrease 95%. Let's say 95% 1-year survival. If it is successful, it will relieve the pain and reduce the ST segment elevation. And this is the procedure if you are interested to see. This is the plaque with the occlusion one. This is the catheter guide wire. And here a balloon has been expanded and you see the lesion has been opened. Then after the balloon there was expansion, and then you put a stent to maintain this opening. Again, this is for interest. I will not ask you about any question about these details. This is just to know. This is the angiography. Putting the dye, and there is no progression of the dye or little progression. This is the area of obstruction. After you open the artery, this is the flow again. Here there was no flow, little flow, and this flow. There one term, angiography, is just giving the dye and seeing what's there, how many lesions, how many arteries. When you put a guide wire, stent and balloon, this is angioplasty. If angioplasty is not feasible, you cannot do it, or the hospital is away from the patient, then try to dissolve the thrombus. This is called thrombolytic therapy, medical, by drugs. It will reduce mortality and maintain that for 10 years. Again, in the first 12 hours, most beneficial, especially in the first 2 hours. Actually, after 12 hours, it is of no benefit because already you have necrosed muscle. Just remembering the physiology, normally this is the endothelium and this is the clot, which is mainly platelet and fibrin and RBC. The idea is to dissolve this fibrin. Normally, physiologically, this fibrin is dissolved by plasmin, which comes from plasminogen. So plasminogen is normally available in the circulation. It's activated by plasminogen that converts the plasminogen activator. It converts plasminogen to plasmin. This plasmin will dissolve the. So if you bring an artificial plasminogen from Streptococcus intravenous bolus, you can destroy the fibrin and open up the circulation. But again, this is a thrombolytic therapy or fibrinolytic. The major hazard is bleeding, especially intracerebral bleeding, where there is 4% 4 per thousand. And there are other relative contraindications to thrombolytic therapy when a patient is having active internal bleeding, previous intracerebral hemorrhage, uncontrolled hypertension, recent surgery, recent trauma, high probability active peptic ulcer, and pregnancy. Step 2. Step 1 was analgesic. Step 2 was reperfusion. Now step 3 is antithrombotic therapy. This will include antiplatelet and anticoagulant. I'll go a bit detail on this. Antiplatelet, it will improve survival and decrease mortality by 5% risk reduction. The prototype is aspirin, cyclooxygenase inhibitor, given orally, 300 milligram, and it should be continued indefinitely. With aspirin, there is another group of drug called ADP inhibitors or P2Y12 inhibitors in combination with aspirin. The best is ticagrelol, this is the dosage, or prasugrel, or the third one, which is available in our market under the name of Plavix, is clopidogrel, initially 300 milligram, then continue by 75. This is dual antiplatelet for every patient with acute coronary syndrome. Continue both for 3 to 12 months, 3 months usually, and then one of them indefinitely. In patients who are high risk, especially those are undergoing PCI angioplasty, you will give a third inhibitor of platelet, which is the strongest one. The final common pathway of platelet aggregation is glycoprotein 2, B3A. You give the receptor antagonist for this. This is called tyrofeban and apiximab. So this is the third one, but is given intravenously with aspirin and ADP inhibitors. This is all about antithrombotic therapy. Antiplatelet. The other thing is anticoagulant. These will decrease thrombotic complications and prevent reinfarction, whether in the absence of reperfusion or after successful reperfusion. Just concentrate on this point. Patient with ST elevation MI, you will give him thrombolysis, plasminogen activators. With that, to support this, you will give anticoagulant heparin. Patient with ST depression and T inversion, to prevent propagation of the thrombus, to prevent thrombus being complete, you give low molecular weight heparin. So the heparin has a role in both complete ST elevation and in ST depression. The instability is prophylactic. There are three types: unfractionated heparin, fractionated, and pentasaccharide. This is the unfractionated heparin. This is factor 10, and this it will take all these together. This is the unfractionated heparin. They have fractionated this part to take only this factor, and the thermal pentasaccharide to take this one. You can look to detail of this fixture. I don't like to confuse you. You have unfractionated heparin, fractionated, and pentasaccharide. Pentasaccharide actually is more practical. Fondoparenix or low molecular heparin for 8 days. Some patients who have atrial fibrillation, evidence of extensive MI, or echo shows thrombus, then you might continue with oral warfarin. So, to summarize, anticoagulants are given in both types of acute coronary syndrome. In complete occlusion, it is a support for thrombolysis. In partial occlusion, it will prevent. But sometimes you might need to continue with warfarin. And the types are pentasaccharide and low molecular weight are more practical. Now, the fourth group of drug are anti-anginal. This is not given for all patients, so don't mention it routinely, please, when somebody asks you treatment of acute coronary syndrome, because this is individualized. The oral or sublingual nitrate in unstable angina or threatened infarction only. IV nitrate when you have recurrent persistent ischemic pain not relieved by morphine or left ventricular failure. Beta blockers, you have two types of administration, two: earlier and late. Intravenous beta blockers, atenolol or tenor or metoprolol, within 12 hours, it will decrease pain, arrhythmias, and short-term mortality. But be careful, you should avoid it in heart failure, hypotension, and bradycardia. So this is a very useful drug given earlier. It will prevent arrhythmia and even sudden death. You have early beta blockers, and later you have, on discharge of the patient, you give oral, this was intravenous, oral beta blockers that reduce mortality by 25%. The third group is calcium channel blockers. Actually, they don't have any much use in MI, especially, but only if you have post-infarction angina. So the most important anti-anginal is beta blocker, IV earlier and oral later, and sometimes intravenous nitrate for resistant pain. The other group of drug is renin-angiotensin blockade. It has been shown that long-term treatment with angiotensin converting enzyme inhibitors like enalapril or ramipril can counteract ventricular remodeling. If you remember the remodeling, the thin segment and the thick segment, can prevent the onset of heart failure, improve survival, and even reduce the recurrence of MI. So they are very beneficial in overt heart failure and asymptomatic LV dysfunction and preserved LV. They should be given for all patients, especially those with extensive infarct, but again, be careful, those with hypovolemia, hypotension, acute renal failure, they should not be given. If the patient is intolerant to AC inhibitors due to cough, etc., then you, or angioedema, then you give a receptor blockers like valsartan and candesartan. The other group of drug is mineralocorticoid receptor antagonists. This is again individualized for certain patients with acute myocardial infarction and left ventricular dysfunction when you have an ejection fraction of less than 35, and the patient is having either diabetes or heart failure, pulmonary edema. Heart failure progressing to bulimia, they will benefit from mineralocorticoid receptor antagonist. There are two drugs, iplerenone and spironolactone is available in our city. The other lipid-lowering, this is for all patients with acute coronary syndrome. All patients should receive HMG coenzyme reductase inhibitor, the so-called statins, irrespective of serum cholesterol, because it has been found that these statins have non-lipid-lowering effect. But if you have high serum cholesterol, you might give the atorvastatin, not 20 milligram or 40, you might give 80. If still higher, you might add another drug like ezetimibe, fibrate, anion exchange, and the injectable new drugs, PCSK9. These are, so lipid lowering, statin, normal dose, high dose in when LDL is high, and sometimes another drug. The other is smoking. This is very obvious. The 5-year mortality of patients who continue to smoke cigarette actually double. So there is doubling of mortality. You should clearly explain this to this patient, and giving up smoking from patient side is very effective treatment. Diet and exercise, I think you know all this. Maintaining ideal diet, eating Mediterranean style, taking regular exercise, that's say 20 minutes per day, brisk walking, achieving good control of hypertension and diabetes. And lastly, the last treatment is rehabilitation. As long as you have infarct, this is a dead area, it needs healing in a matter of 4 to 6 weeks. So physical activity, strenuous physical activity should be restricted for 4 to 6 weeks. If you don't have complication, you can mobilize the patient on 2nd day, return home on 3rd day, and return walking 4 weeks, and even he can drive in some countries up to 4 weeks. Of course, emotional problems should be dealt with, and there is something called implantable defibrillator. I will talk in a minute. This was early management of acute myocardial infarction or acute coronary syndrome. What about the management? Late management, when you discharge the patient from the hospital. Of course, you should have risk stratification because you need further investigation and further assessment. Lifestyle modification should continue, like diet, weight control, lipid-lowering, cessation of smoking, and regular exercise. Then secondary preventive therapy should continue, especially for atherosclerosis, antiplatelet, beta blockers, AC inhibitors, and statin, and sometimes control of diabetes, not always, control of diabetes and hypertension, and sometimes mineralocorticoid. Rehabilitation and device. This is patients with acute myocardial infarction and low ejection fraction heart failure. They are liable for ventricular arrhythmias and sudden death. You can prevent this by implant a device called cardiac defibrillator. This is called implantable cardiac defibrillator. The last topic, I know it was a bit difficult, is prognosis, because the patient has the right to ask you, what is the prognosis of my disease? You can prognosticate him according to the residual myocardial ischemia, according to the degree of myocardial damage, according to the presence of ventricular arrhythmias. Why? Because death, 1/4 will happen before any medical care. Half of them will die within 24 hours, 40 will die within first month. Of course, unstable angina mortality is less. Cause of early death is arrhythmia. Cause of later death is due to extent of myocardial damage, related to extent of myocardial damage. What are the unfavorable features in your patient? If you have poor left ventricular function, if you have AV block, if you have persistent atrioventricular block, persistent arrhythmia. Regarding prognosis, if you compare, it will be worse in anterior than inferior. It will be worse in you have bundle branch block and higher markers in comparison with those with no cardiac markers, if the patient is old age or depressed or socially deprived. Reassure the patient that survival is more than 80% for a further year, 75% for 5 years, 50% for 10 years, and 25% for 20 years. Thank you very much for your listening. I hope this was a useful lecture. It is mainly dictated for 4th-year students. Also the 6th-year students should benefit. If you have any question, you can ask me, and thank you very much.